I work in this community. It's a community of fantastic physicians, great health systems. And so my self-understanding is where I add value is with complex, multi-organ system, multi-morbid, mysterious illnesses. I'm a relief valve for colleagues. If you've ever had that feeling, oh gosh, Mrs. Jones is on the schedule today, what am I going to do? That's a form of something that could drive burnout. Well, this is where I can be helpful. So a relief valve for fellow physicians, a relief valve for frustrated patients. And in doing so, it's clear that I can save someone a ton of money in addition to heartache. So ideally, what my practice now focuses on the 5 fundamentals: breathing, eating, sleeping, moving, as in balance, strength, flexibility, exercise, and loving, or connecting, living a life of meaning and purpose. In every case, I certainly build upon kind of the metabolic fundamentals, informed by the basic sciences, and with oftentimes esoteric laboratory tests and genomic analysis. And my mission is to generate new questions. What hasn't been asked yet? You've seen great doctors. What hasn't been asked yet? New hypotheses. What can we test? And identify laboratory to do this, and hopefully I do this in a respectful manner. So this means I'm often operating where there are no randomized controlled trials. What does this look like now? Well, takes us to the next story, multimorbidity. Our patient is a 72-year-old gentleman who comes in to see me. His past history is chronic depression, refractory to multiple medications over multiple decades, chronic fatigue, unexplained, chronic widespread pain, unexplained, chronic IBS, diarrhea predominant, life-disrupting, no better, and a chronic, slowly progressive pancytopenia, idiopathic pancytopenia. This is what he wrote in our first visit. I want to walk out of the office with more hope. It's very hard to function. I wake after 9 hours of sleep and I'm still tired. I don't have the emotional or physical strength to accomplish much. This is frustrating, and I'm on a cycle becoming more depressed, more frustrated, more helpless. And this is despite having a great team. He had a top-notch internist, a cardiologist, a gastroenterologist, a psychiatrist, a hematologist, and despite great efforts over many years, he was no better and maybe even worse. What do? Take time. Listen deeply. Generate new hypotheses. Obtain new measurements. In doing so, I identified 9 reversible causes that could be addressed by inexpensive, non-toxic interventions. And the result was really good. Woohoo! Is his approach. It's kind of like, yes, down to 1 bowel movement a day. If we look at some of the quantitative measures, it's kind of like he came in with a fatigue score of a standardized scale of 60 being the absolute worst, at 37. A year later, 19. Pain, 36 out of 70, pretty significant interference, down to 20. 13 for the PHQ-9, down to 10. Improvements across the board, and these continued improvements for over time. So we had to publish this, and we did so. And I called him up and said, hey, congratulations, we got published. And by the way, how are you doing? He goes, great. My sons just took me skydiving for my 75th birthday. Wow. Okay, this is awesome. I'm so glad it was published. And then I thought this was such a happy story, but it's different. and this is where we come into the danger zone. What followed was a storm that I think undermines advancement of patient care. It undermined an understanding where slow medicine is sorely needed in the care of chronic, complex, multi-morbid, and mysterious illness. And this is what I learned in lesson 5. Bell curve thinking can represent a tyranny of the majority. So let's go and remind ourselves of the bell curve. You know, we know this also well. 1 standard deviation from the mean is 68% of people. 2 standard deviations is 95%. You've got a right tail, we've got a left tail. And the average person, most people are here in the middle. Some people are doing fantastic, maybe some people over here. But these are kind of the standard definitions. But it's very important, though, to ask a question, what is normal? Who is normal? And who decides? What's your reference population? And this is my fear, that evidence-based medicine has evolved into a form of the tyranny of the majority. Because by definition, randomized controlled trials demonstrate that what on average, for most people, works to some degree. And that degree is what we call the number needed to treat. And evidence-based medicine works really well with systems that focus on population-based health. The greatest good for the greatest number. And we calculate that degree of good by the inverse of what we call the number needed to harm. This generates then additional questions. What is a reasonable number needed to treat? 50, 100? For some cholesterol things, we want to treat women for 800 women for 10 years to prevent 1 cardiac event. Well, there's a value judgment in that. And that's what hasn't been made clear. Behind every mandated standard is a value judgment. And that value judgment may not be shared. And it can be imposed against one's will under the guise of science or the definition of quality. And I think this has led us into a new era of medicine. I call it the era of informed coercion. Now, I'm 58 years old. I'm old enough to have lived through several eras of medicine. The first was what we call paternalism. I, the physician, know what is best. Based on my experience, based on my education, I know what is best for your medical well-being. And then that transitioned to an era of informed consent. I, the patient, know what's best. Whose life is it anyway? But now we have a new thing. We have informed coercion. Big data knows what is best. I, the health system, know what is best for you because we have the data. We know what quality is for you. What does this look like? Well, Mrs. Jones, you need to go on a statin. But doctor, why? Why is that? Well, your cholesterol is high. And the national standards for quality mandate that with your levels and your risk score, you need to be on a statin. But doctor, well, if I don't want to be on a statin? I'm sorry, but the quality guidelines are very clear. You need to be on a statin. But doctor, can you guarantee that I will benefit from being on a statin? Well, no, but on average, for most people, the data demonstrates that there's likely to be benefit. Doctor, how many people do you need to treat to guarantee benefit? But doctor, you guarantee that I will not be harmed from taking the statin? Well, no, we can never report on long-term safety from short-term studies. But in general, the current studies demonstrate that for persons with similar numbers to you, there's more benefit from harm in aggregate. But doctor, I'm more than a few numbers. What about all the other measures I'm taking for optimal cardiovascular health? Aren't they meaningful? Well, I'm not aware of any data to support or refute that. Bottom line, if you don't go on a statin, I'm punished for not practicing quality medicine. Please take the script. And this is the danger. This is what I call bell curve thinking. The personal has been replaced with the impersonal. Consent with coercion. Primacy of the population over the primacy of an individual. Gosh, Mrs. Jones, it's kind of like what is most important to you is not what is most important to the system. And in thinking about bell curve thinking, there are a lot of flawed assumptions in it. First, it presumes that there is an equal distribution, that there's no asymmetric distribution. And we know that is not true. Mean and median are never one and the same when we talk about populations. But you can hide you can hide subpopulation distinctions by saying that they're one and the same, lumping it all in. And it's a form of lies, damn lies, and statistics along that line. And it presumes that there's no such thing as a fat tail. Now, that is events or things far away from the mean may be statistically have a greater likelihood of happening than what's assumed by a normal distribution. And for any of you in the room remember long-term capital management, LTCM, and its big blow-up, despite having 2 Nobel Prize-winning economists on its senior staff, they presumed that life was a bell curve. And it wasn't, and they lost billions of dollars and had to be bailed out by banks all over the world. So my fear is that in the focus on the greatest good for the greatest number, on what works on average for most people, we ignore the left tail. And whether that's 2% or 16% of the people, in absolute numbers, that's a lot. We live in a community of what, 3.5 million people, a state of maybe 6 million people? What is 2% of 6 million? It's a big number. And the left tail is where we find the patients with chronic, complex, multimorbid, mysterious illness. And this is where territories where the randomized controlled trials don't exist, where there may be no evidence-based medicine, and what works on average most people doesn't work. And that was the case with our 72-year-old gentleman. So you can imagine my heart sink when there's an outcry and a team of physicians wrote a scathing letter to the editor about publication of this article. As Permanente, this was in the Kaiser Permanente Journal, who aspire to practice medicine and evidence-based medicine, we were surprised to see that you would dare to publish something that did not represent evidence-based medicine. A case report with outlandishly good outcomes and no practicing evidence-based medicine. Attributing the patient's improvement to the multitude of interventions is at best dubious. It could have been just random. Unless and until clinical trials demonstrate efficacy of this approach, we strongly urge you to not publish such case reports and not subtly or not so subtly encourage physicians to think like this. Now, even the founder of evidence-based medicine thought differently. Good doctors use both individual clinical expertise and the best available external evidence, and neither alone is enough. And I swear to you, I went looking for randomized controlled trials on chronic depression, chronic fatigue, chronic pain, chronic IBS, and idiopathic pancytopenia. And I couldn't find any randomized controlled trial on patients like that. It didn't exist. And I believe in randomized controlled trials. I've conducted them. I'll continue to conduct them. I'll continue to publish in them. But this is my fear. As we work to standardize across the system, processes across the system, we're creating a one-size-fits-all medicine, grounded in single variable thinking, and not for multimorbidity interventions. And patients who deviate from the norm are inconvenient or even painful. In one-size-fits-all medicine, the further one is from the mean, the more force is needed to squeeze them in to first deviation thinking and first deviation algorithms. And when this doesn't work, which unfortunately is often, there's iatrogenic or system-induced harm. One form of harm, the search for efficiency, encourages cherry picking or hot potato passing. The truth is that persons with complex, chronic, multimorbid, and mysterious illnesses are inconvenient. They're chaotic, nonlinear, unpredictable. They take time. Their problem list or review of systems can be overwhelming, and they don't fit into any templates, much less a 20-minute visit. The hot potato is from ER to primary care to gastroenterology to psychiatry to ER to a feed-forward, non-resolving loop. Signs of this: having multiple doctors, no diagnosis, or just descriptive diagnoses, chronic fatigue, chronic pain, not better despite multiple efforts. And my heart goes out because what I'm hearing often is that these types of hot potato patients, when passed around, can feel dumped, dismissed, denigrated, discounted. They leave appointments discouraged. They leave appointments disempowered. And from a healing perspective, these are profound forms of harm done by people who are dedicated to doing no harm, who are dedicated, have an oath to be, staunch advocates for patients. And sadly enough, sometimes these patients are mislabeled as having anxiety or depression, or all too often a conversion disorder. Sometimes if their cries for relief are not heard, are not responded to, they escalate their cries until they are mislabeled as having a personality disorder. So, my opinion is that we need to be aware of the potential tyranny of bell-shaped thinking. It's ego-seductive, and I need to ask whether we're worshiping at the altar of evidence-based medicine.